Welcome to the Orthodontics in Conference podcast, where Farouk brings you the summary of key lectures from orthodontic conferences around the world, with your host, Farouk Ahmed.
Hello all, welcome to an episode of Orthodontics in Conference. I'm really excited today to bring you guys the AAO's virtual annual session from June 2021, which happened just last weekend from the date of recording this podcast. We've got some of the biggest names and the biggest lecture topics on the first day. So this podcast is going to be covering 14 of the lectures from the first day, and credit to the American Association, this year the virtual session has been put on fantastically well, really eclipsed the previous year's virtual session. Topics that we're going to be looking at are aligners, TADs, mini-screws and expansion, biomechanics, anterior open bites, 3D metal printing, Forsus appliances. It's a fantastic line. And just to recap, this podcast is my opinion and may not be 100% accurate, although we try our very best to make sure it is. The podcast is not endorsed by an institute or by the speaker, and is my independent work and that of the Orthodontics in Summary team. It's not intended to override or replace the requirements for clinicians to have to become familiar with the relevant training and guidelines in treating patients themselves. I'll catch up with you guys at the end of the podcast to give my opinions and thoughts as to how the day's gone. I'll see you guys at the end. This lecture is entitled Simplified Mechanics for Aligners in Treating Complex Cases by Chris Chang. Now, Chris Chang's lecture focused on what can be done prior to aligner therapy to make treatment more predictable. And Chris says on average now he spends 5 to 6 months prior to aligner treatment delivering this pre-alignment mechanics. He described some of the benefits of using aligners. They are push mechanics, but their drawbacks are that they cannot deliver pulling mechanics. Chris then delved into the literature and described how we know for extraction cases, aligners are poor at delivering anterior torque, they're not great at delivering expansion, specifically bodily, intrusion for incisors is not particularly predictable. And also second molars tend not to move particularly well with aligners. So Chris has a list of solutions to this, and that involves using auxiliaries such as elastics, overcorrection in our biomechanics, attachment design and power ridges, but also using temporary anchorage devices, as we know, one of Chris's favourite topics. So he gave some scenarios as to where pre-aligner treatment takes place. He gave the example of extrusion of a posterior molar. We know from the literature moving sevens is not particularly great with aligners. However, using a posterior TAD, we can therefore achieve pulling mechanics to upright a molar tooth. He described large spaces are a challenge with aligners. But in this case, we can go back to having fixed mechanics. Some sectional mechanics with buccal and lingual space closure accelerates that process taking place. Deep bites can be a challenge, specifically in patients who are class 3. So for this, Chris gave a top tip, and that was to create a chairside anterior bite turbo. Now for this, what he uses is flowable composite and puts it on the lower 3 to 3, canine to canine. It allows a patient to disocclude on the posterior teeth and prevents them going into a deep reverse overjet. Now, when it comes to scissor bites on posterior teeth that are over-erupted, a real challenge when it comes to most mechanics, but very specific to aligners in the challenge that they have to correct this. So how does Chris manage this? Well, he puts in a posterior bite block using glass ionomer cement, and on the unaffected side. Now, on the affected side, he uses a buccal shelf TAD in the posterior region. Now, what does this do? Well, this allows intrusion to take place of the over-erupted posterior teeth, which is usual, and also allows the lateral or buccal movement to take place, allowing correction to take place of those two dimensions, both vertical and buccal. Now, he mentioned that buccal shelf TADs have a very reduced failure rate compared to average TADs at around 7%, and that was from his paper in 2015. Chris also introduced the idea of a ramus TAD. Now, this is one I've not heard a great deal about, but he used it in a specific circumstance. He used it for a rotated 7, and he placed it in a horizontal fashion in the ramus. Now, he uses a really long TAD, a 14mm one. He described the failure rate for this as even less than that of buccal shelf TADs at 5%. He mentioned there are some apprehensions. This isn't a common use of TADs. And he described anatomically sometimes we worry about the lingual nerve, but he mentioned how when we position it lateral to the terminal molar, actually we're going to be in a very safe zone with the nerve much further back the TAD was inserted. Finally, Chris spoke about impacted teeth and how he described using a temporary anchorage device with his 3D lever arm. Now, the 3D lever arm is a 1925 stainless steel auxiliary wire attached to the temporary anchorage device by flowable composite. And the idea is he can allow 3 directions of control to take place: anterior, posterior, labiolingual, but also can allow torquing movements to occur as well. And his preference for impacted canines is to position the TAD in the infrazygomatic area. This allows him to then extrude the canine, retract the canine, and also carry out buccal movements. That's the end of Chris's lecture, always entertaining and always full of great clinical pearls. The next lecture is entitled The Evolution of Mini-implant Assisted Midfacial Expansion, the Latest Developments and Advanced Appliance with Woon Moon. Now, Woon Moon is the pioneer of the MSE, and that stands for Maxillary Skeletal Expander. Now, he started off describing that the time of closing of the palatal suture has now fallen into question because of the use of temporary anchorage devices with mid-palatal expansion. He described cases of patients up to the age of 50 achieving separation without any form of surgical assistance. He questioned whether or not the sutures actually fuse in all cases. Now, the MSE, the Maxillary Skeletal Expander, well, how does it work? Well, it's a temporary anchorage device retained palatal expander. It's got 4 TADs positioned in the posterior maxilla around the first molar region. Now, due to the posterior bone being thin, bicortical engagement is required of the temporary anchorage devices. Now, the position of the MSE determines the pattern of expansion. That's why it's kept posteriorly to achieve greater posterior expansion. So what happens when we use MSE? Well, Woon went on to describe it achieves parallel expansion of the mid-palatal suture. And that's quite different to our understanding of conventional expansion or rapid maxillary expansion, where it's pyramidal or triangular in nature. He also described MSE creates disjunction at the pterygopalatine suture. And he mentioned a paper which cites this occurs in 100% of cases, but actually it's close to 84% where it's a visual difference that we can see when we come to our cone beam CT. Now, one of the key things Moon mentioned was also the vertical changes that take place with MSE. So he described the interzygomatic distance that expands also when having MSE take place. So it's not just at the palatal level, it's higher up as well, and described up to 4.4 millimeters of change occurring, and also the naval cavity getting larger by 5.3 millimeters. Now, is it stable? Well, he described what is the stability of expansion when it comes to other appliances. Well, tooth-borne expansion appliances, on average, we achieve 6 millimeters of expansion, but we have about 2.4 millimeters of relapse, and that's by Schifferman in 2001 and the systematic review. What about surgically assisted rapid palatal expansion, or SARPI? Well, Chamberlain showed in 2011 the intermolar distance does relapse, and the skeletal component of that is around about 41%. So coming to the topic in hand of MSE, well, there is no significant literature showing what the relapse is. Woon's cases look as though they're stable after 2 years, but he conceded that we need some stronger literature in order to answer that question. So what is the difference now between MSE and MARPI? So MARPI being Miniscrew assisted rapid palatal expansion. Well, this terminology sounds similar, but he demarcated there is a difference. And the key difference is the vector of force created from MSE compared to MARPI. The position of MSE is more posterior to MARPI. Therefore, there's a greater posterior vector taking place than there is with conventional MARPI. MSE achieves a parallel expansion, according to Woon, whereas MARPI still achieves a triangular expansion similar to conventional rapid palatal expansion. There was a study that looked at 50 patients and showed that parallel expansion does indeed take place with MSE. Well, what about comparing now MSE to SARPI, surgically assisted rapid palatal expansion? Well, when this was looked at, it was found that MSE achieves greater expansion at the zygomatic level. And that makes sense because that's the point of rotation for MSc. Now, when it comes to SARPI, actually the center of rotation is where the Le Fort 1 cuts are made, so it's at the maxillary level. So therefore, SARPI achieves less midfacial changes than MSc. Now, what Woon postulated is that can MSc create a difference to the functional matrix? Can there be a change that takes place at the nasal level which results in significant change? So he carried out an assessment looking at CT scans to look at, well, what are the changes that take place to the overall skeletal structures? Now, he found that actually majority of the changes that take place due to MSc are skeletal in nature and only 4% are dental alveolar. Now, there are advancements with the MSc. Now, he describes the process can take place in a completely digital planning format using DICOM data for cone beam CT and also using an STL file. When it comes to using MSc, he has an expansion protocol which he has considered in detail, but he wasn't able to find something significant either in the literature or from their clinical experience. So what does he do? Well, he activates it until it feels tight and then 1 or 2 screws more. So it may average out at being 5 to 6 turns per day. So it shows there's still some more development in the clinical sense and research sense in developing a firm protocol for this appliance, in my opinion. Woon has also combined MSc with a form of corticotomies, and he's described this as being SMARPI, so surgically assisted maxillary Miniscrew assisted rapid palatal expansion. And this essentially involves using a piezotome between ANS and PNS, making small holes in the palate. This and also scoring off the buttress bone. Now, in this process, he has had clinical experience whereby the patient doesn't respond to MSc, but actually following the surgical procedure, they have then responded favorably to MSc. It is an interesting idea and look forward to seeing more literature about it. Finally, Woon concluded to describing the airway and described there is some controversy within the literature about how it is assessed, whether it's volumetric through the nasal cavity using CBCT data. But what he's concluded with is a study which is in submission at this stage, and it's really looking at the pathology associated with the airway in the form of sleep apnea. And so far with patients who have had MSc and had sleep apnea, he's shown from his results that there is a significant improvement in the OSA and obstructive sleep apnea scores in adults, and look forward to seeing this publication as it comes out. Woon has been a proponent of MSc since its inception, and it's always a joy to hear him speak on the topic and also presenting literature as more and more questions come out on this topic, and I look forward to seeing his future presentations on this still very new and very developing topic. Next is a lecture entitled Biomechanics and Force Delivery Systems, Wires to Screws to Plastic, and this was by Ravi Nanda and was this year's Edward H. Angle Award lecture. Ravi spoke exceptionally well and gave a historic understanding of how we've developed our science of orthodontic biomechanics, then applied it to contemporary applications of it, specifically looking at straight wire and also looking at aligners. So he described how there's been significant literature looking at different types of brackets, but in his opinion, brackets themselves make an insignificant variation, and actually it relates far more how we apply the biomechanics to the bracket, which led him to describe arch wires. He described a significant advancement that took place when nickel titanium was created. He described the properties of the wires show a large application that can take place. And this superelastic property of nickel titanium has really been something which has altered the way we clinically practice. He described how sometimes people can get quite caught up with a specific type of arch wire sequence, and for him it relates more to getting in the largest nickel titanium superelastic wire he can into the patient in order to achieve maximum control for the patient. He gave examples of arch wires and how we can very simply apply biomechanics. He gave the classic Class 2 case and creating an auxiliary wire which would distally tip the molar, a simple lever arm then attached to the rest of the arch wire. This can be followed by Class 2 elastics, thus allowing us to use biomechanics with the straight wire appliance in order to achieve ideal results. He then went on to describe forces versus moment, and he described how in his own training and experiences, we got very encapsulated by the force, the specific number that's delivered. But in his opinion, it matters far more as to how and where we create the moment. Citing headgear as an example, that the force is less important, but the direction, the moment of the outer bow really is the key factor to delivering tooth movement. So then, Ravi then spoke about temporary anchorage devices. And I really like this part of the lecture because he described how they first came out and were clinically applied, mistakes he made, and how he then corrected them and published on the same topic. So he described temporary anchorage devices when they first came into inception, were then used with class 2 cases with direct retraction of the anterior teeth, and this resulted in an increase in the overbite. This led to a series of publications by Ravi, one in 2014, where he then looked at, well, where is the center of rotation when we use TAD mechanics? Then some publications were described subsequent to that, where he then showed applying the center of rotation with our biomechanics at different levels, resulting in different tooth movements occurring. Really then showing the application of the science of biomechanics to this appliance of temporary anchorage devices. Next, he went on to describe aligners. Now, he described how the path of aligners has been different in our clinical practice because we've become dependent to a degree on the company showing us how to move teeth. And that's not how we've developed our arch wires. It's not how we developed our temporary anchorage devices. So he described the advances in aligners and engagement with biomechanics have now resulted in our better clinical practice with them. And our basic understanding is that it's the deformation of the plastic that delivers the force. We've got auxiliaries now which really help out, pressure areas, attachments, and use of elastics. Now, what's interesting, he delved into the literature, and he described how force levels differ depending on the amount of activation in the aligners. Now, he was very keen to describe the limited literature we have exploring these questions, and therefore we are still at our infancy in understanding how aligners work. He described a really interesting paper that looked at different levels of activation of an aligner and showed that actually after we've had a number of hours of activation of a 0.2 millimeters, the typical activation of an aligner, we lose up to 40% of that force after only 7 hours. Now, we said that in clinical practice, we may have moved to 7-day changes for our aligners, but it's interesting what the literature shows. Maybe we should augment that, maybe we should vary that depending on the biomechanics. He then went on to describe aligners and attachments further. Now, different attachment designs for canines have been explored by Ravi and also Ojima in a paper which is in press, and their conclusion was interesting, that when it came to canine movement, it didn't matter what the shape of the attachment was. What was key is that there was an attachment on it, and it generated a movement predictably. What was interesting is that without an attachment, there was consistent, uncontrolled tipping that took place. I thought Ravi's lecture was a very well delivered lecture. I very much enjoyed looking at the historical development of appliances and technology and how now we should really be applying that same developmental processes going forwards and also to anything new which comes out as well. Next is a lecture entitled Aging of the Occlusion, What Should We Know? This was by Daniela Garib. So this was an interesting lecture which looked at what happens long-term to patients' dentition and has given us some very precise numbers at the end of it. And it was interesting to listen to. So what Daniela started off by describing is that generally we've known from the literature that males tend to have a forward rotation as they grow older, females have a backward rotation. However, when it comes to our literature, doesn't go beyond the age of the 6th decade, and that's really what Daniela's study looked at. She found 22 patients. They were followed up from the age of 13 up to the age of 60, and they looked at the cephalometric changes, but also the study model changes of these teeth. Now, at this point in the lecture, I'm thinking, okay, this might be interesting, but it's not going to really relate to my clinical practice. And that's when Daniela mentioned is that if we know how patients' teeth and jaws are going to develop, it then does impact on how we treat them in their formative years, as we may be predisposing them to look not as good as they grow older if we're unaware of this. So she brought me back into the lecture and I carried on listening. So what they found was that the crown height increased. Now it varied massively between 0.5 millimeter to 3 millimeters. And she put this down to passive eruption and gingival migration. So both things take place as we grow older. Interestingly, the mesial-distal tooth size decreased by 0.3 millimeters. So everything's getting narrower as we grow older. That interproximal wear is still taking place. Mandibular incisor crowding increased by 2.5 millimeters. Okay, so that supports what we understand about late low incisor crowding. And we have a number to associate with that average amount of crowding that takes place. Went on to describe there's usually a reduction in the overbite, and she put this down to late mandibular growth. She described how patient satisfaction at the age of 60, and this was interesting, is that they were generally satisfied with their occlusion, but they were concerned about the colour of their teeth. Interestingly, none of the patients out of the 22 wanted to have orthodontic treatment at that stage. Now, what Daniela did is that they carried out a superimposition of the teeth at the age of 60 to the age of 13. They looked at multiple landmarks to ensure that this process was robust, and the lower arch, what they found was that there's a reduction in the arch length, as we know, but actually how does that happen? The direction of movement, and I think this was the interesting bit, is that the lower incisors retract in that process of aging. The molars mesialize, and the premolars lingually tip in, and all of that results in the reduction in arch length. Interestingly, when it came to the maxilla, they weren't able to find reliable landmarks. So we all generally tend to jump to the third palatal rugae when it comes to the research side as being heralded as to being reliable. And she found that was true in their testing. However, when it comes to 40-year follow-up, actually the palatal rugae undergoes significant change in its morphology, no longer making it reliable. Finally, Daniela looked at the soft tissue changes from cephalometric assessment. And what she found was that there's a decrease generally in the nasolabial angle. There's also greater lip protrusion, both upper and lower. What was interesting is that they were able to correlate a number to the reduction in upper incisal show. And it was an average 1 millimeter per decade of life. I thought this was an interesting lecture, which does have some relevance to clinical practice, to know where do patients end up when they grow older, to help infer how we decide things when they are younger about our treatment planning. Next lecture is entitled Applying Science to Aligner Mechanics and Design by Dr. Brent Larson. So Brent gave a very dynamic lecture in which he started off by describing a conversation by two clinicians about how to increase torque expression in aligners. And there are two ideas these users put forward. One was that of increasing the trim level from scalloped to a straight margin, and the second spoke about increasing the stiffness. So Brent was caught with this idea and then carried out some research to explore it. Now he set the scene by giving some more information from a literature perspective. He described how the movements of teeth with aligners in Chang's paper in 2021. Now he carried out superimposition of the CBCT on the STL file, so a really robust process of finding out how the teeth actually move. And what he found was that actually the biomechanics of clear aligners are not fully understood, and we can't predictably work out what's taking place. So that's the state of play currently. He then described the accuracy when it came to aligner planned movement and achieved movement, and this was by Grundheld in 2017, and showed that overall the outcomes were good, but were consistently poor when it came to transverse changes, but also torquing movements. So this brought us to the main part of Brent's lecture, which was a study carried out looking at the different margins associated with aligners and the force delivery and strain as a result. Now it was ex vivo, so it was carried out in the laboratory. Now what they did is that they took two aligner materials, Essex material and Zendura, of the average thickness of 0.03. Now, they carried out a design of study looking at three margin designs. They looked at scalloped, the one associated with a line. They looked at straight cut at 0.7 millimeters beyond the gingival margin, and one looking at straight cut 1.5 millimeters beyond the gingival margin. Now, there are companies such as Sirona who do have this as an option for their aligners. Now, what were the results that they found? So they found that the force delivery was greater when it came to the straight cut and the 1.5 millimeter extended margin. Now, what was interesting was the level of discrepancy between these two. So they found when it came to moments taking place in the crown, so to achieve torquing changes, it was 2 to 3 times greater the force moment that was generated, which is a massively significant finding to come out of this study. Now, of course, this was a laboratory study, and further trials are needed in a clinical sense to work out what's actually happening to these forces. But I think as a starting point, to know that we can address some of the discrepancies with aligner therapy with extending the margin is a great starting point to have. Now, Brent, before he came on to his conclusions, then showed this really interesting slide looking at a CBCT and looking at an aligner on a model for tooth and an activation with the aligner. And what he showed is that there is a gap which is consistently generated between the tooth and the aligner when there's this activation. What he didn't manage to then go on to was to explore, well, what are the consequences of this? But it's an interesting idea to explore in itself. Ben described there is more literature needed on this topic, clearly, but also looking not only at the trim, but also the thickness of aligners, relief cuts, and what consequences this have, and therefore will become more efficient and improve our understanding. I really enjoyed Brent's lecture. I think he had a question as an inquisitive person, which he then explored scientifically, and I really feel as though that's a great finding that he's come out with in his study, and look forward to seeing more on the same topic. Next was a lecture entitled Suggestions for Systematic Treatment of Orthognathic Surgical Patients with Clear Aligners. This lecture was delivered by Moshiri. Now, Mars started off describing the advantages of clear aligner therapy specific for orthognathic surgery. He mentioned how it's a preference for patients. He mentioned how arch coordination, elimination of interference can be planned very precisely, but also it features very much so in the digital planning pathway, making the whole process digital from beginning to the end. He described in a very hands-on sense how to go from beginning to end with planning aligner cases in this digital pathway for orthognathic surgery. He started off at the planning side of things. He described getting data from a cephalogram as is convention, clinical, but also looking at cone beam CT data and incorporating that into the process of our STL files. He described one of his tips is to always have 2 to 3 setups when it comes to orthodontic planning for combined orthognathic cases. And he goes and ensures that we have the same ideas of outcomes as our surgeons. By having options, we can explore them rather than being limited. Now, practically, when it comes to planning the cases, a bite jump can be organized for orthognathic cases. This gives us that virtual change that takes place to the occlusion, and we can see numerically what the changes have been. We can also do the setup with our planned decompensation prior to it to see what coordination is also needed prior to planning our case. Now, at this stage, there will be a consultation with the surgeon, and there will be a plan to decide on what type of surgery there will be, whether it's 3-part, SARP, and also planning for any dental extractions at that stage. Then fast forward to the pre-surgical stage. So now at the pre-surgical stage, the patient has been decompensated. He spoke about how leveling the arches is a key component to pre-surgical planning. He described if you don't level the arches, our anterior-posterior correction hasn't been correct, so therefore we're limiting the actual surgical correction that can then take place. He mentioned leveling is key. We achieve it through using attachments and anchorage attachments specifically. Now, he mentioned this, and on previous lectures he has as well. And I think it's always important to remember that when it comes to using Invisalign, the SmartForce hierarchy of attachment placement does not put intrusion and leveling of the arch particularly high up. It's 5th on the priority list, after expansion, root movement, and single tooth vertical changes. So we as the clinicians have to be tuned in to know what our objectives are and what the hierarchy should be in our attachment design. A top tip from him was to intrude the 7s to avoid occlusal interferences. Now, around the time of surgery, well, how do you manage that with an Invisalign case? He described using passive aligners up to the run-up to surgery for approximately 2 months. And he said that's because we always get a lag with aligners in delivering our planned prescription. And this just allows that to take place. He also spoke about having cutouts between the upper canine and the upper first molar. This allows us to have buttons placed easily post-surgery and allows us to attach elastics and guiding elastics. One of his other top tips are to ensure we get this lag resolved. Sometimes using a stiffer aligner or a Rivera retainer is a great way to do it close to time of surgery. Now, post-surgery, what happens? Well, he sees the patient at 3 weeks. Patient starts their physiotherapy at 4 weeks' time, and refinement starts at 2 to 3 months after surgery. Now, his focus at this stage is to eliminate any occlusal interferences using inter-arch elastics and also ensuring that the posterior interferences and anterior interferences are resolved appropriately. Sometimes he will use TADs to allow intermaxillary fixation to take place, but mention how it can irritate patients. We have to be aware of that. Now, when it comes to using a splint, he spoke about conventional splints that are used, intermediate, final, and palatal splints for segmentals. But actually, Invisalign also produce a guided splint. Patients can use this for 2 to 3 weeks. It has reduced retention compared to the conventional aligner and has holes in the occlusal aspect to act as a guide. He then spoke through a couple of cases, and they were fantastically treated cases. Now, the one that I want to home in on is the jaw joint replacement case. Now, it was an anterior open bite case with arthritic changes in the jaw, and he planned both a biomaxillary advancement, total jaw replacement. Now, Invisalign delivered the decompensation for this case, and the case was treated fantastically well, in my opinion. Now, Mars has very kindly put his notes for the lecture on his website at www.alignerfellowship.com at the bottom of the website. So please feel free to go there and have a look at his lecture with the clinical photos of his patients. This lecture is entitled Efficient and Effective Growth Modification, a 30-Year Perspective. This was delivered by Lorenzo Franchi, and this was the Jacob and A. Salzman Award Lecture for 2021. So Lorenzo starts off describing the timings for treatment. He described how mandibular growth from prepubertal and pubertal is a significant change to the amount of changes to the mandible. He quoted approximately 1 millimeter for prepubertal and 3 millimeters of change when it came to pubertal growth using a functional appliance. This was Perrottini's paper from 2015. So he described what does happen to prepubertal patients who have class 2 treatment. He mentioned how mostly the changes are dental alveolar. He mentioned how lip competence does improve, but no real changes to the skeletal structures. However, when it came to looking at pubertal patients, and for this he used the cervical vertebral maturation stage 3 to define it, actually the significant changes that take place to the mandibular length. So what are the favorable features in Lorenzo's opinion when it came to growth spurts? Well, when it came to predictable growth, around 3 millimeters of change can be achieved. That's Perrottini's systematic review. He mentioned how it's far more efficient to time it for this period, as a shorter overall duration in treatment, between 2.5 millimeters for patients who are pubertal versus prepubertal at 4 years, and that's Tulloch's paper from 2004. He also described the long-term effects of functional appliance therapy. This is Pavoni's paper from 2018. And here they looked at treatments of patients who are prepubertal and pubertal and looked at, well, what was the overall difference in stability? Now, in the prepubertal group, there was no difference in mandibular growth with a functional appliance. That suits our understanding, as we know there's no significant change taking place for these patients skeletally. Any small change that do happen on acceleration, and actually there's a deceleration following this functional treatment. However, they found in this study pubertal group were remarkably different. They had a 5.5 millimeter increase in the length of the mandible, and long-term wise, this was maintained, and they judged this approximately the age of 18. So the understanding here is that during the pubertal period, at least according to this study, that functional appliance therapy stimulates mandibular growth as opposed to just accelerating it. Now, he mentioned how individual response is also variable, and there have been some predictive factors. Now, Franchi's famous paper from 2006 looked into this, and he established the mandibular angle. the condylion, gonian, and menton angle. And what he found was that if this angle was less than 123 degrees, patient had a great response to the mandibular length, and it was the only predictor they found looking at variable cephalometric outcomes. Poor responders were patients who had 128 degrees or greater. Now, when it came to looking at other changes that take place and planning treatment, he looked at class 3 cases. So the treatment timing, so Franchi's paper from 2004 showed that rapid maxillary expansion and face mask can be used before puberty, CVM1, but also looking at pubertal timings at CVM3. And what they found was that for the patients who were pre-pubertal, they had 2 millimeters of maxillary change. If patients were pubertal, so CVM3, there was only a significant change in the mandible. Now, the explanation of this from Lorenzo was that maxillary sutures, the time of their closing results in resistance to protraction taking place. And he mentioned how the pterygopalatine sutures are open prior to puberty, but very much start to interdigitate at the timing of puberty. He mentioned when it came to class 3 cases, there is still an individual response which is variable. He described how clinical outcomes are usually the success and absence of a crossbite. Now, he showed that in a long-term study looking at protraction face mask and rapid maxillary expansion, success rates were approximately 70%. This is a long-term study by Suki in 2019. Now, the predictive factors for success here, well, the condylar axis, the mandibular plane, and what they found here was that if the condylar axis was drawn from the point on the condyle, passing the midway point through articulare anterior, and essentially intersected the mandibular plane. If that angle from the condylar axis to mandibular plane was 147 degrees and less, it was a successful case. If it was greater than 147 degrees, it was an unsuccessful case. And he found this to be a very reliable predictor when it came to sensitivity and specificity. So what was a conclusion from Lorenzo's lecture? Well, he said that the timing for class 2 cases is pubertal, the time for class 3 cases is prepubertal to maximize skeletal changes. My opinion on this particular lecture was that there seems to be a divided camp on changes to the mandible with functional appliances. Lorenzo very much was in the camp that we can have skeletal changes which are long-term maintained. But then when we look at Kevin O'Brien's lectures and studies, we find that actually overall long-term wise, there was no significant change to the mandible. Perhaps we need to have some multi-center, multinational studies to explore this topic further. This lecture is entitled Type of Approach for Biomechanics of Aligner Orthodontics. This was by Kenji Ojima. Now, Kenji spoke about the integration of data, and Kenji has a paper at the JCO in 2019 which describes this in more detail. But essentially, it's about data from the images from the patient's face, a JPEG, using a cone beam CT or DICOM data, and the STL file from scanning the patient's teeth. And he described this approach as being an anatomically driven simulation planning, looking at the face, crowns, root. And he described how once this data is accrued, how they then plan the case. He starts off with treatment goals, then looks at the biomechanics, and then does the movement simulation. So he gave a series of 4 cases which highlighted utilizing this information. The first was an anterior open bite case, and he was able to use this data to work out how much extrusion of the patient's anterior teeth would be possible to take place and still have good bony contact. When it came to looking at molar intrusion, he was able to assess the density of the bone, specifically in the mandible, to see if intrusion was or was not possible. Now, the second case was an extraction case, and again, Kenji has published this in the JCO in 2020. Now, it's a case of missing lower 5s, retained lower E's. Cone beam CT was taken, and it was able to assess the bone density to see if retraction of the upper anterior and posterior teeth was possible. What was the quality and quantity of the bone on the palatal and lingual aspects? Once he had found out the anatomical boundaries and limitations, he was then able to plan the biomechanics. He also gave a tip about retracting anterior teeth with aligners and described it were unlikely to achieve bodily movement. And he quoted Rossini's systematic review from 2015. So what's the solution to this? Well, it's about manipulating biomechanics. He spoke about intrusion of the anterior teeth from the same study was shown to be reliable. So if we intrude at the same time as retracting, we're able to impart more predictability to that tooth movement. The next case was an extraction of 6 cases, and described for this case biomechanically. What he used is a conventional attachment on the 7 or the second permanent molar and a vertical position of it to achieve ideal biomechanics to stop the tooth from tipping. The fourth case I felt was the most interesting out of all of the cases presented, which was a Class 2 Division 2. Now, he had taken the cone beam CT, as well as the facial images and the STL file. So he analysed where the E-line was, he analysed the bony content present labially to these teeth. Now, classically in a Class 2 Division 2, we may plan to procline the upper and lower incisors, but in this case that was not going to work advantageously. From a facial perspective, the patient was already lying on Ricketts E-line with upper and lower lips, but also the bone quality on the labial aspect was very minimal. So instead, he planned biomechanically to intrude and torque the upper incisors, to distalize the teeth posteriorly to create space in order to facilitate these torquing movements. So Kenji's conclusion was we should look towards having anatomical digital data and then plan our biomechanics. This lecture is entitled Ideal Occlusion is Not Always the Ideal Treatment Plan by William Dayan. Now, I enjoyed listening to William describe this lecture, describing occlusal compromises, but saying that they're ideal for the patient considering the other parameters. And I think it's an interesting one to explore, one which has a biomechanical perspective, but also a very much a patient-centric approach to achieving that outcome. So he described a series of cases. He started off looking at a Class 2 retrognathic mandible case. If a patient has now declined orthognathic surgery, we're going to have to accept an occlusal compromise to a degree. In this case, it was not idealizing the inclination of the incisors, but still achieving ideal alignment and smile aesthetics for the patient. When it came to looking at a Class 3 case, he described extraction of a lower incisor. Now, he said, yes, we do accept that in these cases, canine guidance isn't going to be ideal, midlines aren't going to be correct, nor is the molar relationship. However, compared to the alternatives of either orthognathic surgery or extracting 2 lower premolars and protracted course of orthodontic treatment, actually it does meet the patient's objectives with respect to alignment of the teeth and is also far more efficient and effective to achieve the outcomes of treatment. He then went on to describe an asymmetry case. The mandibular midline was shifted to one side. He mentioned how we can use asymmetric elastics. However, this can result in adverse biomechanics and can create a cant. So what's William's approach to this? Well, he likes to use asymmetric biomechanics. So he likes to use an asymmetric curve of Wilson, differential torque, and tipping in the teeth on the affected side. He mentioned how, yes, there is still a centerline discrepancy at the end of the case, but he says that this was better than balancing the adverse effects of using cross elastics. He finally went on to speak about a severe anterior open bite case with a posterior crossbite. Now, he described how, rather than extruding teeth, he prefers to allow teeth to fall together, as he termed it. And that essentially is posterior intrusion, allowing auto-rotation to occur to resolve the anterior open bite. Now, what's interesting here, he mentioned how he accepted the crossbite on one side. And he mentioned because the dental alveolar bases were so distant from each other that actually it would be a challenge to correct, challenge to maintain. This was the stable position for the patient. It was a very interesting lecture approaching a topic of compromise, but also saying it's ideal for the patient. And I'd really like to see William and other speakers describe this topic of when compromise is ideal for patients and how do we achieve limiting the compromise that we also do for these patients. William gave some really interesting ideas of biomechanics, but I really feel as though the compromised outcome means so much to different people that we should be working towards, well, how do we limit those compromises and where do we accept those compromises? This lecture is entitled 3D Metal Printed Boneborne Appliances by Simon Graf. Now, Simon described his enthusiasm around 3D design and how that's led him to now plan his Boneborne expansion appliances using a digital pathway. Now, he described two broad methods of doing this. 2 stages where the TADs are inserted, followed by impressions taken to the lab and then design the appliance, or second, doing it all in one go, TADs and insertion. Now, he generally prefers a 2-stage process due to not trying to avoid being overbearing to patients. So how does this process work? Well, it all starts off with a scan. Now, he mentioned how actually scanning TADs in the palate is a challenge, partly due to the shiny nature of a TAD, but also due to the undercuts not being captured well by a scanner. Now, just recall a scanner fires off light which is perpendicular to the scanning appliance, so therefore if there's an appliance at an oblique angle, like a TAD tends to be, it's not going to capture that surface, specifically the undercut. So how can you get around this? Well, he spoke about some neat tricks using powder spray in the undercut, but also if the laboratory has digital analogues of the TAD, they can then position it and still plan the appliance. So he spoke about the use of a Hyrax appliance, custom molar bands. He mentioned how these fit so well, it can be a challenge to remove. So his top tip was to essentially have a thin point in the band so it's easy to cut and remove the actual band when it comes to debonding. Now, he spoke about distalization. Now, he talked about planning distalization as well as intrusion can be achieved through TADs. Now, when it comes to putting in an appliance of this nature, those mechanics have to be pre-planned, and therefore the vectors also in delivering the appliance itself. And then he spoke about the difference between a distalizer and a distal slider, as similar as those terms are. So a distalizer is the appliances that Simon uses. Essentially, it's a custom-made product with the vectors bore in mind in the creation of the product. Now, a distal slider is different. It refers more to the Benny slider by Benedict Wilms. And essentially, this is a prefabricated appliance which is produced and inserted and bent either chairside or in the laboratory, and achieves the vector of distalization. Now, he prefers the distalizer as the vectors are essentially calculated from the concept, from the inception, and delivered accordingly, whereas a distal slider has the potential for adverse biomechanical effects. Now, he spoke about different softwares out there, and what I quite liked, I'm sure Simon has his preference, but he gave a very broad view as to what's possible. He described 3Shape, Ortho App by Onyx. He described AlignTex, ExoCAD, and MexiMesher. Now, he advised using a dental software just because it has pre-settings, which makes it far easier to use for dental planning. Now, I think what I enjoyed the most was when Simon then started to show some cases. Now, there was one case where the canine wasn't ideal, and you could see his frustration as he described this case, and he wished for those extra 2 months of settling prior to perhaps taking those photos. He mentioned the material which is used for a custom-made 3D metal appliance, and cobalt chromium seems to be the material of choice. It's very stiff, it can't be bent, so it means the vectors have to be planned well in advance. There's no way back after it's produced. He mentioned how the manufacturing process takes place. Now, there seems to be a mix here of going from selective laser melting, which Simon tends to use, looking at quicker processes, such as binder jetting. Now, in the binder jetting, there's always some constriction that takes place, as we tend to shortcut some of the processes, but actually it's far easier to do. Now, Simon's published a number of papers on this topic. He's got a publication, the AJODO 2017 and 2018 on this topic. And what I loved about Simon's presentation at the end, he said for anybody who wishes to carry out this process, send him an email to help design their first product. What a chap. I look forward to hearing more from him. This lecture is entitled Tips to Optimize Treatment Results Using Forsus Class 2 Corrector. This was by Dr. Lisa Alvetro. Now, she described the advantages of using a Class 2 corrector, the lack of patient compliance that's needed, the adaptability. She spoke about using it in AOB cases, deep bite, also maxillary distalization and for anchorage. Now that was a key part of this particular lecture. Now I hadn't come across utilizing class 2 correctors in that fashion, so I was really interested to see what she had to say. She described the different components of the Forsus appliance, but also actually how they impact on how the appliance is used. Whether we're using headgear tubes which are occlusally facing or gingerly facing start to change the vector. She also described how the rod is key point as to how much activation takes place of the spring, and also the arch wire. We can change these factors to alter the vector and force generated. Now to summarize how this can be manipulated, so if we want to achieve greater posterior intrusion, for example, well then we want to have more of a vertical vector. How is that achieved? Well, that's done by positioning the Forsus appliance in the premolar region, creating greater intrusive vector in the upper posterior teeth. This may well be advantageous for anterior open bite cases. Now, when it comes to achieving more of a horizontal vector, well, actually, we probably want to go to the canine as the point of attachment of the Forsus. Greater horizontal vector, less intrusive forces taking place. She went on to describe a classic deep bite case with reduced lower anterior face height. She mentioned positioning things and the Forsus anteriorly, so we're getting it anterior to the premolar in the canine region. This allows some intrusive force to take place on the lower incisors, but very much reduces the intrusive force on the upper molar teeth. She described how using a lower TMA arch wire with bite opening curves will also aid the process. Now, her top tip for deep bite cases was not to bond the severance. This was news for me because I always felt with class 2 correctors we needed full control. But no, if you don't bond the upper severance, it allows them to over-erupt and therefore helps correct the reduced low anterior face height, all making perfect sense. She then went on to describe a high angle case. Well, here we want to have that posterior intrusion occur. So for that, we're going to position the Forsus in the premolar or even the second premolar region, getting higher intrusion. As she mentioned, it's important to ensure the sevens are bonded in these cases to prevent that over-eruption. When it came to look at the arch wire, she said, well, actually a flexible arch wire is going to enhance this process far more than using a rigid stainless steel in the upper arch. But we can utilize the lower arch for anchorage in a vertical sense. So for this, she uses a rectangular stainless steel wire in the lower and using a flexible nai-tai wire in the upper arch wire. Therefore, more posterior intrusion occurs. Also spoke about including perhaps bite closing sweeps to aid the anterior open bite correction. Finally, she spoke about using Forsus for anchorage. So in a case where we've carried out extractions, I thought these mechanics were really interesting. So the Forsus appliance goes on in the conventional position, upper molars down to the lower canine region, but also nai-tai closing coils are used in both upper and lower arches. And she described this as being really advantageous in a class 2 extraction case. The nai-tai closing coils stimulate the retraction of the upper anterior teeth, and in the lower arch we get protraction of the lower posterior teeth. This is enhanced by the vectors with the Forsus appliance. Remembering that in the upper arch, the Forsus appliance has a distal vector to the molars, in the lower arch, the Forsus appliance has a mesial vector to the lower anterior teeth. There are a multitude of resources for Forsus available, but the YouTube channel I did check out after this lecture, and it was fantastic to watch when it came to insertion and removal of the appliance. I do recommend you guys have a look at it. This lecture is entitled Key Factors to Consider When Correcting the Vertical Dimension by Flavia Artese. So Flavia started off describing the principles of vertical management. For deep bite cases, we're looking at anterior intrusion and passive posterior eruption. Anterior open bite cases, we're looking at the opposite, posterior intrusion and anterior extrusion. So she started off by describing TADs and how we can utilize them, but we have to be aware that intrusion to the anterior teeth can affect our smile aesthetics, and intrusion of posterior teeth for AOB cases can affect function. We need to bear this in mind in planning our cases. So she described anterior open bite management and to consider the smile line. Usually in AOB cases, we have an inverted smile line. So she described using intrusion of sixes via TADs. This creates a clockwise rotation of the maxilla and increases the incisal show. She mentioned incised extrusion may be unstable, but sometimes we do require this movement for facial aesthetics. I thought that was a really neat point to mention, is that sometimes clinically we perhaps have to go down some of these realms. When it came to deep bite management, she said to also consider the smile line. Now, if a patient already has a consonant smile, then intrusion of the upper anterior teeth is going to flatten the smile. In these cases, we should move our mechanics to posteriorly. We know that 1 millimeter of posterior extrusion has an effect of 3 millimeters on the anterior segment. Flavia went on to describe stability of intrusive and extrusive movements, and she described posterior intrusion. We know maxillary molars will relapse 12%, mandibular relapse is 27%. That was Espinosa's systematic review in 2020. So we have to bear in mind the stability of our movements. When it came to looking at patients' occlusion, she described the occlusal vertical dimension, which is the distance from the nose to the chin at maximum intercuspation. Now, when we have deep bite cases, this will change. And the study showed by Liu in 2018 that we can have around about 4 to 6 millimeters of increase. But interestingly, there's always some relapse that takes place over a 2-year period. Overall, there's an increase, but there is a relapse in that distance. Flavia then went on to describe some of the etiologies of reduced vertical dimensions, and she described how gastric reflux is a key component to that process and erosive wear consequently. She mentioned how if we are seeing this as doctors, we need to ensure that we are managing the pathology taking place and refer appropriately. She described in managing cases, how do we do it in these combined cases? Well, first of all, the posterior occlusion needs to be restored restoratively, then orthodontic treatment. And that's very clear why. As Flavia explained, as we open up the patient posteriorly, they become more class 2. And of course, that's something we can then address with the orthodontics. Next, Flavia presented an interesting class 3 case. A patient had attrition. They also had reduced upper incisal show, which is common, and increased lower anterior show due to lower over-eruption. So she mentioned how she biomechanically managed this case. It was starting off by increasing the occlusal vertical dimension through posterior molar extrusion with upper and lower fixed appliances and class 3 elastics. Once this was done, then Flavia intruded the lower anterior teeth. So there's a significant change taking place to the lower occlusal plane. She described that when it came to OVD changes, we don't have any strong research when it comes to it. This is a prosthodontic paper by Goldstein in 2021. I mentioned the changes that take place are variable, and there's little evidence to show how and if we're able to keep things stable. The idea that if we change the OVD, it depends upon muscular adaptation, and the clinical evidence at this stage suggests it is stable, but we need more information. I enjoyed Flavia's lecture. I think she tells a great story, mixing academic and clinical information to tell us what the overall picture is of a particular topic. She's featured on the podcast a few times and has been interviewed. I look forward to hearing more lectures from her. The next lecture is entitled Anterior Open Bite Correction, Conventional Treatment versus TADS. This was by Jay Park. Now, Jay started off describing tooth movement for anterior open bite correction in orthodontics, and it's simply 2 directions of movement. Either it's extrusion of the anterior teeth or intrusion of the posterior teeth. Now, he gave indications for these 2 types of movements. Extrusion of anterior teeth, usually in patients who have normal or decreased posterior alveolar bone or have no excessive gingival show or reduced. Now, when it comes to patients for posterior intrusion, we're looking at the high angle cases, the brachycephaly or the increased low anterior face height cases, also in case they have gingival excess display. Now, he described where do we draw the line when it comes to anterior extrusion. Well, it comes down to the gingival show on smiling. This was investigated by Kokich in 1999, and he found that actually lay people found up to 4 millimeters of gingival show on smiling acceptable. Interestingly, orthodontists were less at 2 millimeters. Now, what was also asked by Jay was that does the actual patient's face type make a difference to the amount of gingival show which is acceptable? I think it's an interesting question, and he's involved in the paper by Lima in 2019. And what they found was that for long face groups, 3 millimeters of gingival show was acceptable. However, comparing that to the patient with an acceptable facial balance, 5 millimeters of gingival show is acceptable. So this is now starting to indicate that actually the facial type should feature in how we then diagnose the patient's gingival show. When it came to temporary anchorage devices and anterior open bite management, he described the conventional mechanics versus temporary anchorage devices in a very neat study by Deguchi in 2020. And this showed that with conventional mechanics, anterior open bites were generally resolved through anterior extrusion of about 3 millimeters in upper and lower arches. When it came to using TADs, there was intrusion that took place, around about 2 millimeters to the upper arch, 1 millimeter to the lower arch. Now, Jay did address the stability of this movement, so the intrusion with TADs in this particular paper was found to be less stable, around about 30% relapse after 1 year. Jay then went on to describe, well, where do we position TADs if we want to carry out posterior intrusion? He gave some options. We could go buccal, but mentioned that actually the interradicular space is small, and actually as teeth intrude, that gap gets narrower, can result in mobility of the TAD. He mentioned how the palatal area is ideal. Interradicular distances between the first and second molar are 6 millimeters, which is ideal. He also mentioned the area between the 6 and 7 is preferred to the area between the 5 and the 6, and that's because it's more efficient to create intrusion posteriorly, and that's really where we want to generate the moment as it is. He described TAD mechanics. He described using a modified TPA, arms on the TADs themselves, which are positioned parasagittal in the mid-palate, and simply using power chain from these TADs to the molar teeth for intrusion. Now, he mentioned sometimes there is some rolling in that occurs through this process, but we can apply some buccal crown torques to correct for that. He described how the occlusal plane does change when we carry out intrusion. There's also auto-rotation, which then takes place. So he mentioned anticipating this occlusal interference by carrying out retraction and intrusion of the lower anterior teeth prior to our posterior intrusion. I thought it was a top tip from him in managing these cases. In conclusion, Jay mentioned that increased lower anterior face height with increased gingival show, we should be aiming for posterior intrusion with TADs to manage AOBs. Posterior intrusion should be both upper and lower. He mentioned if we just do one arch, we're likely to get compensatory eruption in the opposing arch. And we should place the TADs as posteriorly as possible, as it's the most efficient way to achieve intrusion. That brings us to the end of the first day, guys. Hope you've enjoyed the wrap-up of those 14 lectures. I think there were some mega topics addressed here. What was interesting is that nearly every lecturer mentioned something to do with temporary anchorage devices or aligners, and actually a lot of them had both of them in their lectures. I think I'm taking from this is that we are now really starting to develop from a scientific and biomechanical perspective aligners, and not just by manufacturers. The use of temporary anchorage devices is really versatile. Using a class 2 corrector in an anterior open bite case sounds really interesting. It's something I'm going to be keen to try. And actually coming back to anterior open bite cases, getting back to the fundamentals of are we going to do posterior intrusion or anterior extrusion was a real theme in the last couple of lectures. I think we need to get back to I need to get back to the diagnosis of these cases before I start planning what mechanics I'm going to use. Hope you guys enjoyed this lecture. Next week we'll bring you part 2, which will be day 2 of the AAO. I'm excited to do that. Some great lectures coming up. And of course, if you do like the podcast, please do subscribe and look forward to the next episode.